Today, we have a pleasure of hosting a panel that will be discussing short-term medical missions. I'm particularly thrilled to be hosting this group since I know them really well, and I've been spending a lot of time with them, meeting them about once or twice a month for the past 3 years. And I've been always struck by the wisdom that I get from just those interactions. If you have any questions for the panelists or me, please type it in the Q&A box and I will post it to the panelists. And now to bring in the panelists. First, I'll bring in Myron Aldrich. Myron has had extensive experience in corporate structures around the world before his involvement in NGOs. He's currently the chairman of a unique NGO, Medical and Surgical Skills Institute, or MSSI, in Accra, Ghana, that does an amazing job of being a nodal agency in organizing training for healthcare providers in Ghana and various parts of West Africa. Myron, welcome. Can you tell us a little bit more about yourself and your engagements with short-term medical missions, and also how you look at them these days?
Great. Yeah, thanks, Charlie. And also thank you for inviting us to the mini med school discussion today. Regarding my background, yes, as you mentioned, I do have a combination of corporate and NGO background. I spent 25 years in the corporate as a corporate marketing executive, primarily in international marketing, working with companies like Kraft, Samsonite, and an office furniture company called Herman Miller. And at Herman Miller, I was president of Asia, opening up the China market. Well, during the time we lived in China, my children developed respiratory problems due to the terrible pollution there. So we moved back to the States, and I switched to charity work, working with medical NGOs, primarily focusing on medical equipment and supplies. Well, Johnson & Johnson, recognized my corporate background and my medical equipment experience. And in 2005, they asked me if I would help set up a surgical and medical training center in Ghana, West Africa. So for the last 15 years, I've been coordinating medical training for Johnson & Johnson across, Africa. During my time I was in Africa, I saw a lot of medical mission trips, volunteers coming and going. And most of the volunteers were very good professionals, caring, taking time off from their valuable practice, coming over and helping people who may not normally get health care. However, I also saw some volunteers who were like medical tourists. They wanted to see the world, do medical practices, but came in with a sort of superiority type of attitude, looking down on the local conditions, the doctors, being insensitive to culture, health system, and causing problems. So I saw both, good and bad. Charlie, you asked about an aha moment. Here's sort of that story. About 5 or 6 years ago, a very good U.S. NGO came to Ghana, one of the better U.S. NGOs, and they wanted to conduct specialized surgical, procedures there in Ghana. So they met with the Minister of Health of Ghana, and he said, great, we don't have that surgery here. That'd be great. So he gave him permission to do that. So the US NGO went back to the States, raised millions of dollars, returned, conducted these surgeries, all for free, free surgery, free medicine, and again, very good quality, surgery, helping a lot of people. Well, unfortunately, it turns out that Ghana actually had 5 doctors who did this type of surgery, not as sophisticated, but doing those procedures. And this NGO ended up putting 2 of the 5 out of business, taking their work away from them and, basically ruining their practice. Well, the US NGO heard about that and went back to the Ghana doctor who's in charge of this area. And they apologized, said, we didn't know that, can we figure out how to do something and work together? Well, this Ghana doctor is a very good person, said, yeah, let's figure out how we can do this together. Well, the US NGO said, well, that's great, but first we want to make sure everyone there in Ghana, the doctors, are qualified to do this quality work. This doctor they're talking to was educated in Oxford. He was the head of the University of Ghana, surgical skills in the area. Quite frankly, he was much more qualified than any of these, US doctors, coming in here. and was greatly insulted, by this whole procedure. Now, taking a step back, the US NGO did everything right in their perspective. They went to the Minister of Health. Again, you go to the top person to ask permission. Well, ministers of health are often political appointees, and this person was actually an accountant working on universal health care. So he didn't know all the technical areas. The NGO did it for free. Their donors wanted all the product, all the services to be done for free, so they did it for free. They also did what their policy requires, is to make sure anyone that does it is quality. So they did absolutely everything right from their US organization, sending organization perspective, but obviously all wrong from the Ghana perspective. Fortunately, this has a good ending to it. The two got together and worked it out to where there was actually a way that they helped each other focus on the in-country, and things have worked out over time. But the aha for me was that conducting short-term medical missions is not easy. Clearly two sides, the host country perspective, the sending organization, and to be successful, you have to really understand the local needs, not what the sending organization wants to do, but what is really needed and the local culture. Create mutual partnerships driven by the host country, the local community, and for sustainability. So Charlie, that's a quick background and also how I got into medical missions.
Thank you, Myron. I really appreciate your viewpoint on that, particularly the perspective of how we should be looking at asset-based partnerships rather than a deficit, looking at people and saying, oh, there's nothing there. And I appreciate that.
Great.
And now I'd like to bring in Judy Lasker. Dr. Lasker is a professor emerita in sociology at Lehigh University in Pennsylvania, and has done a significant amount of research on this topic. Her book, Hoping to Help, has been a useful resource to folks conflicted with the emotional pull of being part of a short-term medical mission. A link for that towards that book is in our website too. Dr. Lasker, can you tell us little bit more about yourself and your engagement with short-term medical mission and how you look at them these days?
Thank you, Charlie. I'm a sociologist, as you said, and but I've always had an interest in medical sociology, which is a major part of our field, and have studied many different aspects of health and healthcare. But my first big project was in West Africa, in Cote d'Ivoire, Ivory Coast, next door to Ghana, that Myron was talking about. And I spent a year and a half there, really getting to know as much as I could in that short time about the healthcare system and the needs of the country and so forth, and where there were many problems. At that time, there were very few medical volunteers. There were a fair number of doctors who came from France as part of foreign aid or who lived in the country because France had been the colonial ruler until 1960. And what I was most struck by with some of them was their lack of communication with patients, the lack of understanding, and not really even wanting to. Some of them told me they were happy to get away from France, where consumers asked too many questions and complained too much. And, because they couldn't speak the language in Cote d'Ivoire, they didn't have to deal with that. That was not an encouraging experience, but it was something that I thought was kind of interesting. And then, kind of on the back burner after I finished the degree and started teaching, and I began to notice students starting to go on short-term healthcare trips. And I was teaching a course on global health, so I came into contact with a number of students who were doing this. But I think my aha moment, and I can picture it, was sitting in my office, and one of my students who I had gotten to know pretty well, wonderful young woman, came in my office after a vacation, and she said, I just had the most amazing, life-altering experience. I spent 2 weeks in Honduras, and during that time, we spent a couple of days in an orphanage, we spent a few days doing clinics, we did some tourism. It has changed my life. It's like, great, wonderful. And she said, but then she said, but I have no idea if we actually helped anybody. even though that's what we wanted to do. And that stuck in my head, not only as sort of an interesting comment, but because I'm a curious researcher. Well, what do we know about whether you actually can help people in a short period of time? And it began to sort of percolate in my head. And then I had more contact with students and actually worked directly with a number of students who went on a trip to Ghana, northern Ghana, with a company, and who actually did some research and reported back to the corporate leadership. And the thing that they all of them, actually 2 students who went to Ghana, 1 who went to Haiti, came back saying the volunteers need to be much better prepared. They need to know more about the needs in the country. They are presenting information which is not appropriate because people already know it. The assumption that somehow the local professionals didn't know that much. And they need to have a greater sense of cultural humility and sensitivity. So this theme kind of kept coming up over and over again. And it was really because of those moments that I started to think, well, this is a very big issue. It's growing in size. There are many, many people, thousands and thousands of people who are going on short-term trips. Let me look at it, see what I can find out about whether there is value to it. What are the pros and what are the cons? So that was kind of what got me started. The intermediate result was what you mentioned, is the book Hoping to Help. But it also led me to meet these 3 gentlemen on my screen, and we'll talk a little bit more about what happened after that.
Thank you, Judy. I really appreciate those points. It's now my pleasure to bring in Bruce Compton. Bruce is the Senior Director of Global Health at Catholic Health Association of the US. Bruce has had extensive involvement in global health activities across various parts of the globe. Bruce, can you tell us a little bit more about your background and your engagement with short-term medical missions and how you look at them these days?
Sure. Thank you, Shiley. I'm so glad to be here with you. Well, my background starts in a very different world. I was a stockbroker, and when I went on my first trip to Haiti 23 years ago, and it really, like Judy said, it changed my life, and I thought about how I was helping people with finances and how I might help others. And so I went to work for the Diocese of Springfield in Illinois full-time, working for the church, and subsequently led 13 trips to Haiti in 3 years with no training, no experience. But we felt great. We had good motives. We were taking doctors. We were working with an organization that was there all of the time. I was able to collect what was said to be hundreds of thousands of dollars worth of medicines from places in the United States and take them down there. And then I thought I was really going to do something special. So after those 13 trips, I'd actually been asked to move there after about halfway through those 13 trips to take a job. And my wife was pregnant with our daughter and I was unable to go. But a year and a half later, they asked me again. Our daughter was 2.5, and we decided we were going to move to Haiti. And it was when I really moved to Haiti that I really had my sort of aha moment and gave me my thinking about the way I think about missions today. When I got there, I saw the piles of things that we had taken and other trips like ours had taken to the same facility that were stored because they were not appropriate for what they actually needed. After only a few weeks, I recognized that the volunteers that were coming in were disrupting the normal activities of our 100+ employees that were providing healthcare, whether there were volunteers there or not. And so it really made me take that time to think about what I had been doing, why I had been doing it, and what are these people that are coming here? What are their motivations and what are they actually accomplishing? I think similar to some of the things both Myron and Judy have talked about. And so it really led me to consider how I might be able to change those. And we'll get more into that further into the conversation.
Thank you, Bruce. My story here, just briefly, this is about 3 decades ago. I used to work amongst forest tribes in southern India. And I still distinctly remember we had a tough time in getting the trust. We had been there for years, getting the trust of the community. And we had started some treatment for tuberculosis there, which needs a lot of investment, trust, and long-term engagement. And I remember going to this tribal colony once and then hearing that there were short-term visitors who had come from another country who had told the folks there that the medicines that they were taking were bad and they need to stop taking it. And I was devastated because it had taken a long time to get the community to agree to take these medications. Tuberculosis is a horrible disease. Sticking to the medications is an integral part of it. So, and Judy, Bruce, and Myron, if you remember the first time I met you folks, I said, I hate short-term medical missions. That had imprinted in my brain pretty strongly that it was too disruptive for continued care in communities. So I'm also struck by how, all of us come from different walks of life, and we've all come to the conclusion of understanding short-term medical missions in different ways. And we've come to also recognize that there might be value here. So I appreciate that. I'd also like to look at what have you folks been doing since those initial aha moments? Myron, how about we start with you again?
Sure. Well, a couple of years after my aha moment in Ghana, a large medical equipment company called Medtronics, came to me and said, we give a lot of medical equipment, to doctors going overseas on these medical mission trips. We want to make sure that, that we're doing our best quality practices to make sure this is done right. We don't know if we're open to product liability, to malpractice suits. Since medical equipment in Africa, would you be willing to help us review our policies? And I said, well, I'm not an expert in medical missions, but I'd be glad to help. And I suggested that we work with an organization called PQMD, which is other corporations and other NGOs, and together learn about medical missions and practices. We all agreed. And so I started by learning about what's currently happening and what are the current situations. And there's 3 things that sort of jumped at me. Number one is that medical missions is a very large area. Hundreds of thousands of doctors go overseas annually, spending billions of dollars. Second, there is very little good research or information on medical missions, and almost all that exists is coming from the sending organizations, not the host or not the local community. The third thing is there seems to be a growing awareness of the problem and challenges, and a realization that mutual respect and mutual partnerships are very important, just like my aha moment I saw in Ghana. So this led me to become more involved, more interested in trying to figure out how we can improve short-term medical missions, how to make them appropriate, strengthen the local healthcare system, and therefore sustainable, helping the people long-term. So that's what I've been kind of doing, since the aha moment.
Thank you, Myron. Judy, how about you?
So probably 10 years ago, I really launched the research that I had been thinking about and trying to answer the question of what is the value of these short-term missions, both for the volunteers and for the host communities. Because it seemed to me right off the bat that if they were only good for the volunteers, which I could see from many conversations with students, they were great experiences. But if that's all they accomplished, that seemed really inadequate. It seemed like if people were trying to help, then helping and making sure host communities benefited was the most important thing. And that there was really extremely little research. And I have to say, even today, there's still very little research that actually is able to document the value of these short-term missions. There's a lot of reports on how many patients were seen and how much medication was given out and so forth. But in terms of impact on the health of communities, it is still very, very sparse. What I tried to do with my research was to look at the sending side and say, okay, what is motivating them? What are they doing? And I did a large survey of sending organizations in the US, and then I followed up with a lot of in-person interviews with people who were involved in sending. And I was trying to get at what were their goals, what were their methods, and how did they think, what kind of impact did they think they had? And the thing that struck me really a lot was, so often I would say, so how do you know if you made a difference? Assuming they would have answers, right? Because that's their job. And most often there would be this silence, like, oh, that's a good question. I guess we should evaluate. Or the answers were anecdotes. You know, people thank us. You know, we know that we have helped certain people with surgical interventions whose lives are much better. Again, very little data. So I did that survey, I did the interviews, then I traveled on 2 trips and did some observation, and I interviewed a lot of the staff in host countries, and I had people in other countries. So I had 4 countries where we interviewed local staff. And so I put it all together and came up with what I thought was what I hoped was a pretty comprehensive view, where we were looking both at the positives and at the negatives from the perspective of the host countries, and also looking at how what people were doing matched up with what people in the host countries wanted. So the sending countries, we would ask, do you have a preparation program for your volunteers? Do you have a selection process? Oftentimes, no. If you can sign up and pay the money, you get to go. The people in the host countries really wanted the volunteers to know more in advance and be better prepared. So there was a gap there. The typical stay was between 1 and 2 weeks. The host country staff said, less than 3 weeks doesn't really make a difference. And as Shiley said, and Bruce said, they often get in the way. They need a lot of hand holding. They need a lot of attention. But there's also a sense in which, it's great to have attention. It's great that they shop here and they bring in money in the economy and they give us a little extra boost and so forth. So it is a very complex picture. And what I found most interesting, I think, to me was the variety of short-term missions. And what I love about this group is that we come from some of that variety. So, you've got the corporate, you've got the faith-based, and actually faith-based missions are the most common. Many thousands and thousands of small churches send people on brief missions. And then the academic, which is another big piece of it. So it's a very complex field. And so getting to know it and then working with people afterwards in terms of how to make it better has been really exciting. And that's how I came across these folks. Myron called me and said, I'm working on this project. Bruce called me and said, I'm working on this project. And so we began to work together. And that's been one of the best parts about it, is bringing the different perspectives together and seeing how much we shared in common in terms of our understanding of how this could be done better. Make the best use of the energy and the goodwill and the resources that were going into this kind of thing. So I'll stop there.
Thank you, Judy. Bruce, how about you?
Yeah, so I continued to observe while I lived in Haiti for the next 2 years after I'd really had that moment where I thought, oh my gosh, what am I a part of, or what was I a part of? And I watched the sisters that I worked with after we would receive donations from these volunteers that had been there in the past, go through and sort and try and find the useful stuff that was in there. I talked to the Ministry of Health when I would go to Port-au-Prince and talk to the Ministry of Health and ask them what were their thoughts about these short-term medical missions. And they said, we think they do good. We know thousands of people come into this country, 2 or 3 plane loads a day, but we have no idea what the end results are. I worked with one of my colleagues, and I really brought this idea to her while I was still living in Haiti. And I said, we need to do a short orientation for every group that comes in. And so we began doing that for every group that came into our facility. And I think it helped. It educated some of the people. But then I moved home. And when I moved home, I brought that story with me. I began working for a congregation of religious sisters who owned 13 hospitals in Illinois and Wisconsin. And I started their first outreach, official outreach for the laity, for missions to assist them. And it was really a way to continue that mission of the sisters. And it was to do appropriate medical equipment and supply recovery. Again, one of the big things I saw was that things that were donated were inappropriate. So we brought them in, we fixed them, we put them online to be ordered. If it was supplies, we made them into cases of lots so that people that actually needed them could order them, and we would ship them to them. But from there, I moved I guess also while I was there, I continued to educate many of those that would come and ask for supplies from the local organizations that were going on these short-term interactions. And just talking to them as they would order, asking them, how do you know this is what they need? How do you, how is your understanding? Because we really wanted to ensure they were taking the appropriate things and they weren't making the mistakes I did. While I was at the Hospital Sisters, I had a good opportunity to get to know many of the Catholic health systems around the United States. I also had raised some money to do some research from a foundation. And so when I came to CHA, where I am today, 10 years ago, the first thing we did was a research project on the donations of medical equipment and supplies from hospitals to the developing world. The results we found were quite horrifying, actually. And I wasn't sure how long I was going to keep my job, letting the hospitals know that, 9 out of 10 were donating broken equipment. And they answered the question saying, yes, we donate broken equipment. 6 out of 10 were donating things that were either expired or soon to expire. We went from that to doing research on medical missions. And I worked with Dr. Lasker and Michael Rozier from the St. Louis University. And we had one of the largest research projects on short-term medical missions. And much as Judy said, there was a lot of discrepancy between what we were trying to do and what we could actually prove were happening. And then we have come up with recommendations for practice for our members based on the World Health Organization's Twinning Partnerships for Improvement and African Partnership for Patient Safety recommendations. I've worked closely with people at the WHO subsequently to try and identify best practices, and was invited to join the Global Catalyst Group, which is a group that was from multiple countries around the world, including the WHO, to catalyze institutional partnerships, long-term institutional partnerships that become the home for short-term interactions in global health. And continue to do that today. and am so thrilled that I've met this group of people and we can tell the story really from 3 years ago to now.
Thank you, Bruce. That's actually the perfect segue. We've all alluded to the point when we all, happened to get together in a meeting. Myron, I'm going to bring you to tell us a little more about, if I can call it, the origin story. What were the circumstances that led to that meeting?
Great. You're referring to the meeting in Washington, D.C. In 2017 in conjunction with the CUGH conference. Like I mentioned before, I was doing a lot of learning about short-term medical missions and doing research, and I realized the same names kept coming up. These same experts, a small network. And so I reached out and started to talk to these people. And one of them is Judy, Dr. Lasker. And Judy said, "Hey, I'm working on a poster for the CUGH conference in Washington. Can I add some of your corporate experience to it?" And I said, "Sure, that'd be great." And then, thinking about that conference, Judy said, "Hey, most of these world experts are going to be here. Let's get a side room and invite them and see if they want to come and we can talk as a group to discuss this topic." So we invited 17 people, and to our wonderful surprise, they all said yes. So we had people, experts from different segments. We had people from universities, NGOs, faith-based organizations, government, hospital, medical associations, corporations. So we had this meeting and it lasted almost all day, and it was a great discussion. And we kind of agreed on a number of things. One is we realized that all these different sectors, whether it's universities or associations, all had similar problems. We also realized that it's going to take a real concerted effort to really make a meaningful change. And the third thing is we left the meeting saying, boy, there's a real need here, a real desire to make a change to the current situation. So, well, since the Washington 2017 meeting, a group of 4 people have been meeting regularly. And those 4 people are the people you see on the boxes here, Charlie, Judy, Bruce, and myself. And we've formed the core of AGHP, which is Advocacy for Global Health Partnerships. But in addition to the 4 of us, talking, twice a month or more, we also meet quarterly with a larger group of about 30 medical mission experts from around the world, whether academic, NGO, business, funding organizations, faith-based organizations, or some of the members Bruce has been talking to, international organizations like WHO. And during the last 3 years since we've been talking, AGHP has worked to better define the issues involved with short-term missions, focusing on ways that we think we can improve it, sending and host, and doing this across all the sectors, all the different, organizations and different areas, universities, hospitals, and all the rest. But we realize that this is going to take a lot of work to be done and a long ways to go.
Thank you, Myron, for that. Judy, you've been key in spurring the conversation with some really well-informed research and also asking questions in a good way about this. Can you elaborate a little bit on what you did and what you found, and also your interactions with the Brochure Foundation?
So the research part, of course, is my true love. But I love being outside the academy and connecting the research to change and policy. That's really, to me, the value of it. And all of us, I think, were involved in doing research on this topic, and we're happy to get together and share our findings. But we also were in touch with people who were doing the work, just as Bruce has been doing it with Catholic Health Association, creating materials and guidelines and resources. University of Minnesota, it should be noted, was is a leader in this regard. Tricia Todd at the University of Minnesota Pre-Health Student Resource Center created a series of policies and resources that is really recognized certainly worldwide and nationwide as really one of the best models for how to do this right with students. And I refer you to her work. I think you'll have the reference on the website, Shiley. And Shiley, having worked together with her, you know, they've really taken the lead. So this webinar is really a follow-up. When we put together all these efforts that people have been doing and thought about, you know, what did it mean? How much difference did it make if we were doing research or doing, coming up with guidelines and resources? And in conjunction with that CUGH conference and our meeting, we put together an article about 27 published guidelines for better medical missions. And they came from all different sources. They came from individuals, from medical associations, from NGOs and so forth, trying to come up with standards that would improve the area. So we published this review, and what we noted was that there were consistent themes throughout, and we distilled it down to 6 key principles for better medical missions, and those informed the declaration that we're going to talk about a little bit further. The other thing that was really important in that review, I think, was the finding, again, not surprising, unfortunately, that almost every one of these was coming from the global north, from people who were on the, if you will, the sending end of medical missions. And they were very little informed by the people from the host countries. And that in addition, there was no enforcement mechanisms. So people were putting a lot of effort into writing guidelines, and they would appear in journals and then nothing would happen. So those were 2 key issues that we felt were very important to focus on, was the views of host countries. You know, were we just talking to each other and not really understanding what needed to be done? And also what kind of legal framework could be used to help enforce and provide incentives for people to do it well. So we were very fortunate to get funding from my university, Lehigh University, to fund researchers in 3 countries, in Ghana, Uganda, and Guatemala. These were studies that were approved by the local governments and were directed by researchers from the universities in those 3 countries. We're in the process of writing those up, but I can just say that they confirmed a lot of what we thought, which was good. That people found these programs, these short-term missions, to be helpful, particularly in meeting the needs of rural areas which had very scarce resources. But they felt also that they could be much better, that in some cases they were interfering and taking up a lot of time and resources, that if they were more sustainable, ongoing, if the volunteers knew more about the local language and culture, that they could be much better. And the theme that comes through over and over again in this research and in research done by other people in host countries is the need for respect. That volunteers who come in saying, we know what should be done here, and we're going to tell you because we are Americans or we are British, we know better. This is extremely offensive and ineffective, but unfortunately it happens all too much. So we continue to work on these research projects, and we continue to work on education and advocacy. We're doing a lot of speaking and writing and so forth. But we thought it might be great to bring together all these different groups in a larger forum than in what we had done in Washington. I had been very fortunate while working on my book to be in residence researcher at a foundation in Geneva called the Brochure Foundation, where they host people working in the area of bioethics and health and law. And it turns out they also do conferences. And so we decided to apply to have a conference in Geneva, which of course is the heart of global health, where the WHO is located. and to bring together leaders of global health associations to address these issues and to look particularly at the enforcement question. How do we get sending organizations to pay attention to the ethical problems? How do we encourage or work with host countries to provide more enforcement of their own laws? So we were going to meet in Geneva last May. We had a wonderful group of people who agreed to come, from leaders of health organizations from around the world. And then of course, COVID hit and it didn't happen. But Shiley, over to you. What happened?
Thank you, Judy. This is where I would like to introduce what we have called the Brochure Declaration. And I think the important thing to keep in mind is, in preparation for the conference that we were to hold in Foundation Brochure in Geneva, we were bringing together thought leaders from different communities, different backgrounds, and us sitting together to figure out how to optimize the time at the Brochure conference. And one idea that came up was to have an aspirational declaration. It's also fascinating that entities around the world tend to respect these aspirational declarations a lot. So we thought that would be one way to look at it. In very practical ways, we've always looked at aspirational declarations or ethical frameworks as higher appeals, if you will. You know, the carrot, and the legal framework, where lawsuits and malpractice issues being the stick. So we were looking at doing the aspirational framework. And so we planned a global summit, and the people included, folks invited included representatives from the Consortium of Universities for Global Health, the International Hospital Federation from Geneva, International Christian Medical and Dental Association from London, the American College of Healthcare Executives from Chicago, the European Ester Alliance, the Tropical Health Education Trust, or THET, in London, the World Medical Association in Geneva, and the WHO's Twinning Partnership Initiative. So I'm going to take a quick second here to share my screen so that you folks can take a look at what we call the Brochure Declaration. And the Brochure Declaration, I know some of you are on phone calls right now, and please understand this Brochure Declaration has been uploaded to our website if you want to see this. It talks a little bit about important tenets of global health, that global health is a field that should aim to reduce disparities in health and well-being around the world, and that the ethical framework should be based on mutual respect, solidarity, and social justice, and that the community need should be the most critical driver of these activities. We also emphasize that global health engagement should be sustainable, asset-based, bi-directional, adhere to appropriate legal standards, and be adequately evaluated. And based on this, we talked about the following principles, and you see the principles being listed here. Number one, mutual partnerships with bi-directional input and learning. So what we're hoping is that there is not a significant power differential between the sending country and the host country. That brings us to the second point, empowered hosts and community to define the needs and activities. Quite often the question that comes up is, whose agenda is it? Judy mentioned how, you know, her students feeling really great about this, which is probably good, but it's more important to understand the local community's needs and activities. Number three, sustainable programs and capacity building. Quite often we hear about one-off visits, then disruption of the healthcare system, and no long-term investment. If you're really looking at improved conditions locally, we need long-term investment and capacity building. The fourth one, compliance with applicable laws, ethical standards, and code of conduct. And this includes things like people getting the right license to practice medicine. I'll tell you the number of stories I hear about people practicing medicine around the world without a license is quite cringeworthy sometimes, not to talk about challenges in the ethical standards or code of conduct. And number five, humility, cultural sensitivity, and respect for all involved. And the last one, accountability for actions. And this includes, all of this includes the premise of a proper evaluation where these activities are reviewed appropriately. So we also ended our Brochure Declaration with a call for more people who are engaged in global health to sign up to this and strive towards making global engagements much better. I'm going to stop sharing my screen right now. And also at this time, talk about the absence of the conference, the Brochure conference, made us engage with people in a different way. We've been hosting a lot of dissemination sessions, webinars. All 4 of us in various combinations have addressed different groups. We also uploaded the Brochure Declaration on the website, and I would strongly encourage you folks to review it there. But I would also like, Bruce, if you will, explain how you have looked at the Brochure Declaration and how organizations have been endorsing the Brochure Declaration.
Yeah, thanks, Shiley. Well, CHA was more than happy to endorse the Brochure Declaration. It was actually, in some ways, a dream come true for me because, as Judy said, there are 27 sets of guidelines and principles and recommendations out there that we've looked at. And CHA had one of those sets of guidelines. Too many of those sets of guidelines were felt to me like they were only for the organization that had created them, and in some ways making it possible for them to do it by the guidelines. So I had really hoped, as a member association that has hundreds of our members having teams go, that we could have something that was bigger than us, saying, this isn't CHA saying this. This is a group of people from around the globe really talking about the need for guidelines. So CHA was amongst the first to endorse. We have shared it with multiple other people, but you mentioned several that have endorsed Shiley, including the Esther Alliance. We've had the International Christian Medical and Dental Association. We heard recently on one of our calls that the WHO had shared the declaration with the Esther Switzerland, and they had endorsed. And so we continue to promote this declaration. We think it's helpful. And we also believe this is a way that we as a group, all of us, take our part in helping the United Nations and the 17 Sustainable Development Goals that all of the nations approved back in 2015. One of those goals was to ensure the health and well-being of our global community by 2030. A lofty goal, considering that we have lots of the social determinants of health that need to be addressed in that time to really help with the health and well-being. But we see this as a way to help the UN reach those goals. And it's the 17th goal of the Sustainable Development Goals is that this should be done through partnership. And so I really believe that this leads us to the appropriate lens on partnership and in assisting the United Nations and those member countries, 192 member countries that endorse the Sustainable Development Goals, to help them achieve those goals. If we can help these short-term medical missions become more sustainable themselves, and to be able to talk about the impact.
Bruce, thank you for that. And I particularly like your emphasis on the social determinants of health from the framework of the SDGs. I think this is important because a significant number of people look at global health almost always as a clinical entity, right? A clinical activity rather. And we know that clinical activities contribute to about 10% to the overall health of a community or nation. Important 10%, don't get me wrong, I'm a clinician first, but in the field of global health, I think it's important to look way beyond just that 10% of other activity. So I appreciate you bringing that up. Myron, I'm going to bring you back here. What do you see as a future work for AGHP and this field?
Thank you, Charlie. Yeah, looking forward, as you've heard from all of us, this is a significant need, and it will take a while to make real meaningful change. But what we're going to do is focus on a 3-year initiative to concerted effort to trying to turn the corner, make a transition towards more appropriate, short-term efforts, focusing, of course, on the host countries and the sending. And AGHP, we want to be a quiet bridge, bringing the host and the sending organization and all the sectors within that, universities, NGOs, and all the rest, making it all work. But doing this not for short term, how to do this, making it long term, sustainable, strengthening the local healthcare system rather than coming in for a week and then leaving. And we will want to do this in the whole spirit of working behind the scenes, quietly making this happen, not focusing on ourselves as an organization, but focusing on the important things that are happening in the country and building from that ground back and bringing all these organizations together. So that's what we plan to do in the next 3 years. We spent 3 years sort of learning this. Now we want to spend the next 3 years, following up with the Brochure Declaration and making this and implementing this, putting your practices together and, working towards compliance to make this all fit and really help people around the world and help those in need.
Thank you for that, Myron. I think we have a lot of work ahead of us, is what you're saying. I really appreciate your viewpoints in this, all three of you, and it's been a pleasure having you. I'm going to jump to the question and answers here. The first one is a pretty long question, and the gist of it is, what are the lessons you've learned, most valuable lessons you've learned, that needs to be applied here in the US to improve regional healthcare as we continue to see stressed healthcare systems, particularly now with the COVID pandemic, et cetera, et cetera?
Can I?
Please, Judy.
I want to speak to having worked in a university in which many students did local service projects. And I think the principles that we found to be most important in international work are really similar. I would see students who would sort of walk down the street into the community and say, I'm here to help. And, I'm a smart, well-off college student. Listen to me while I tell you what you should do. Same thing, same problem. And so the whole issue of sustainability, of having the community directing what's being done, not the giver, so-called. I think the principles are very much the same. And anybody who wants to do work in a local community has to find a way to make sure that they are not imposing an agenda which is not the best for that community.
Myron or Bruce, anything to add to that?
Probably just add a little bit to it, and it's almost basically saying what Judy said, but the idea of humility and respect for all. If you view yourself, and them as others, no, listen to them, listen to their understanding, where they're coming from. Again, respect for everyone, whatever background, and that's where it's going to help, that mutual partnership and bi-directional learning, but caring for others and doing what you can to show everyone respect.
Thank you for that.
Yeah, Shiley, I think I would sort of follow up on that to say there's a few things that we have already learned from global health. The community health worker movement that happened in South and Central America, and we used in Haiti, we've gotten far more. We're learning from them how to work in our communities better and to get to know our communities. I think COVID-19 has taught us something that they've had to deal with all the time, about how do you deal with supply chain shortages? How do you deal with a lack of resources, whether that's financial or the actual tools that you need to do your work well? We've really been awakened to the reality of the rest of the world because of COVID-19 in some ways. And I think we can learn from them. I also believe there's a lot of innovation that doesn't have to be the kind of innovation we typically think about. The people that I saw doing work in the developing world in the times that I've traveled are amazingly innovative, sometimes out of unbearable necessity that's really a shame that they have to deal with given what we have here. But I think we have a lot to learn.
And I think the underlying issue in that question is that our systems here are not perfect. There's so much work for us to do in our own backyard. Next question, and I think this is specifically to Judy. Are there any researchers who are currently actively collecting longer term data?
I'm familiar with a few, but really few. I'm in touch with a doctor who's the head of a group that goes to Dominican Republic on a regular basis, and they have a database of patients in the same place, and they are following up to track their diabetes. Are they taking the medicine, and are they showing improvements in the clinical markers for diabetes? That's one very small study, but I think a good example of what could be done. There are people who follow up on surgical interventions to look at the impact. But in terms of the overall, what do these teams actually leave behind in the way of improvements? I have seen very little. And if somebody out there knows of some, please write to me.
And I think one other one that I would like to mention is some of the work that Noel Sullivan has done from an anthropology viewpoint. Mm-hmm. And I like that framework because she's looked at it as what happens with volunteer economies, how much voluntary work or the premise of doing work changes the economical structure and then dependency that is created to aid. Thank you for that, Judy.
Shailey,
go ahead, Bruce.
Shailey, I think it's appropriate at this time to mention there was a group that was doing for 40 years maybe surgical interventions, and I don't know that it's actually been researched, but it was NPR, I believe, did a story on it in their Goats and Soda series a year ago, and this organization had been going and sending surgeons to do surgical procedures for cleft palates and cleft lips for a number of years. They sent the doctors from the United States, and it was really at the request of a local doctor a number of years ago that they began to think about changing their model. And the statistic that they now use is something like 91% of their surgeries now are done by local doctors that they built the capacity for. Instead of going and doing the surgery, they went and trained the surgeons to do the surgeries for themselves. And now 91% of the surgeries done by that organization are done by local surgeons in country. And it's really changing the way we think about it. And I guess in some ways, the good news is that the NGO did not get hurt in their fundraising and other efforts like they thought they might to support helping those in country. They were able to maintain their funding and so forth. So not necessarily research, but I think it's an important topic there. Thank you.
Thank you, Bruce. And I can think of one organization comes to mind like that, Children's Heartlink, who also shifted their model. Instead of sending teams to just do surgery, now they have a long-term relationships where they train local groups of cardiac surgeons and pediatric surgeons to do surgery. And that's significantly increased. But Bruce, if I might ask another question to what you mentioned, quite often we feel that philanthropy can drive this. So my question is, have you folks seen, and I'll start with you, Bruce, have you seen where philanthropy has driven this in a perverse way, negatively? Or have you seen examples how philanthropy has made people do more evaluations and ask the right questions?
Well, I'm afraid I have more examples of the former than the latter. Yeah, frankly, where I was working, when I lived in Haiti, the trips were probably seen by the organization more as fundraising trips than they were actually as clinical interventions and helpful in that way. I really believe that the organization knew that these trips were about the money and the things they were going to gather versus the help that they were getting. And some of those that were the best on those trips recognized it themselves and turned their support into not going on the trips, but sending money to continue to help work on those trips. One was a very good friend of mine who I took on his first trip. And he had his own aha moment at one point, and he said, I'm holding these people up. They're having to translate for me. They know this. They do this every day. And here I am, and I can see this lady that's here helping me is actually just waiting on me to get out of her way so I can do what I do. So unfortunately, I don't have a lot of great stories about the philanthropy other than the one I already talked about. But I do think there are ways that we can make this work so that it doesn't hurt us, but it really helps the people we're trying to help more.
Myron or Judy, any examples you can think of?
Yeah, what I'm seeing, around the world is, charitable, philanthropic, has one need. On the other side, there's the business aspect. And it really takes a combination of both a social business model in a lot of these countries, because if you go in with a philanthropic, 3-year type funding, you will end at 3 years. At the same time, if you go in with a pure business model, it'll end up where a few people control all the wealth and all the money and be profitable. But it's that mix in between to where it's a combination of both of those that's sustainable. And you're starting to see more and more of that. And that really has a lot of promise.
Thank you for that, Judy. Any examples that you can think of?
Yeah, I've part of my interviewing was with people who, Americans who had lived in some of the low-income countries for a long time, and like Bruce, saw volunteers coming, and they would often say, they were there because they were donors and they had an idea what they felt ought to be done, and it made it hard for the organization to do what maybe the staff thought should be done, because the donors had quite a lot of influence. And that's a challenge, because organizations want to sustain themselves. Bruce and Michael Roget, who he mentioned, and I did a paper on what are the goals of the organizations that send medical missions. And oftentimes they really were not about helping, or only partly about helping. They would say, yes, we want to help, but we really want to build our reputation. Every college and university in the country wants to say, we send so much % of our students overseas and they do these great things, and we put stories about them in our alumni magazine and people will give money. Or we can recruit more students because they know they'll have these fabulous opportunities. So bringing up the numbers is a goal. And oftentimes church groups will say, well, this is a way to motivate our church members to make them feel closer to our congregation and give us more money if they can go on a trip and feel good about the other people they're with and so forth. There's nothing wrong with these goals, but they sometimes get in the way of planning trips that will serve the host countries best. So
yeah, I appreciate that. It's almost like asking the question, whose agenda is it anyway, right? So
yeah, exactly.
Sorry, go ahead.
Shiley, I had another thought that just is it's a really old example of how this has been successful. It does come from my background in faith-based, but I work for the Catholic Health Association. And it is because of medical missions that the sisters came to the United States. But unfortunately, they didn't come for short term. They came here and they stayed in the United States, and they built the Catholic health system that is now 600 hospitals. And as Myron said, they built it into a business. They started out as charities, but the sisters quickly learned that they had to become the friends of the business leaders, the friends of the people who were doing industry, and that in those places. And that's how they really turned it into a part of the health system that exists in the United States today. I think we need to think about it more like that. And I think too often, frankly, it's about the money in that it takes to do it. And money is important, but I think Myron's business and sustainable business and charitable, that combination in these places is super important.
Thank you, Bruce.
Can I just
Go ahead, Judy.
add one comment to that on a more sort of positive, hopeful note? Bruce had talked about a group that changed their business model, their model for doing short-term trips. And I think we're seeing more and more of that. And we've already seen people say they're using the Brochure Declaration as a way to rethink the way they do volunteering. And there are groups that we know of, the Catholic Medical Mission Board, that used to send many volunteers all around the world, and they did a very careful study and ended up picking 5 countries that they would have long-term ongoing relationships with, so that the short-term mission is simply a piece of a much larger partnership. And I think when organizations very thoughtfully look at impact and can convince their donors that this actually makes more sense, I think we're seeing some real positive moves in that way.
Thank you for that. Here is more a comment than a question of a person who saw a bunch of surgeons who were not happy when they were, and I'm editorializing this because it's pretty long, because in Nicaragua, they were asked for licenses and surgical history and things like that. And doctors and nurses were really were not happy with this. They got upset, refused to stay, to get to know the country, and left. We've heard stories like that quite often. The next question, I think, this is something that I can answer. What is the University of Minnesota's medical school policy regarding sending medical students to developing countries to learn global health? Our framework has been very strongly that they go as learners, as humble learners, number one. And number two, that they don't displace local learners. That's another important thing to keep in mind as a student, as a learner. If you're going there and disrupting a local learner, you might be causing more problems. And then the third point is we want them to be adequately supervised. So from the University of Minnesota's viewpoint, the same amount of supervision we expect in one of our local hospitals, we want the same one to happen in another country too. Here's a question on examples of successful capacity building endeavors. Myron, could you talk a little bit about what MSSI is doing for capacity building?
Yes, the MSSI, that's the Johnson & Johnson Training Center in West Africa. And here's where, the first 3 years we came in sort of like an NGO approach. We came in, put up a facility, made sure all the money was there to do this. And after 3 years, we realized that, hey, we're going to go out of business. I mean, it's just not the right approach. So we looked at all the different sectors, that came in there, universities that came in, they wanted us to pay for, their trip, their time, and all the rest. The companies that came in, they wanted to get, certain benefits, other NGOs, and we said, time out, this is not going to work. We have to work on an internal system that actually, the people, want to put things in, but they have to get out more than they put in. If they don't, they will eventually leave. So, for example, the universities, they, sent people over there, and we said, okay, well, what would it take for you to do this? what are you getting, and what are you, getting, or what are we giving that works well? We said, well, right now we give you a facility that's, works. You have, the electricity works, the air conditioning. So this third world experience that you want, you get. You get connections with all the different, universities, corporations. So we're making all these connections. Is that worthwhile for you to do this without charging us an arm and a leg for what your effort is? And they basically said, no, that's not it. And I said, well, what do you want that makes it worthwhile? And they said, well, we want the data. What is the results of this that's making this worthwhile? And I said, well, why do you care about that? He says, with that, we can get more money for grants. Oh, so if you get that, you do it for free? Absolutely. Okay. Corporations, you're giving us all this product and all the rest. What are you getting out of it? And this one person says, well, I can just tell you that I'm actually getting business out of this. He said, he came from Nigeria, said, I've been trying to talk to the Minister of Health. He wouldn't do anything for me. He'd never let me in the office. But I went down there, sat in one of the courses, and I got back. I got a $1.2 million Ethicon suture order from that, only because I was involved in this. So I'm getting something out of it, and I'm glad to do it. So we eventually got a system together to where we started charging the students to come and take our courses. We didn't charge the doctor themselves, but we charged the hospital. So when the doctor came in there, let's say it cost $100, we gave them back the supplies and equipment worth about $1,000. So the hospital says, well, this makes a lot of sense. I'm getting $1,000. I'm only costing $100. And the doctor's happy. He says, well, now I actually have the equipment that I can actually do what I've learned. So many times I learn something, I go back and don't do it. The government said, well, this is working so well, we're going to require this to happen. So the organization, our organization got the money for the course. The doctor got the education, the hospital got the supplies, and the government got better education of these doctors around the country. So everyone won, but it only worked because the person that they put something in, they got more out of it than they put in. And that's why it's growing. Again, it's that sort of social business model.
Thank you, Myron. I would like to get one example that from the University of Minnesota was a partnership with the Seoul National University, a 6-year project of training personnel within the university to do further training. And I look at that as a generational investment. You train personnel to become teachers. You create the factory for the workforce of the future, kind of a thing. And I look at capacity building models in that framework too. So. Here are some specific questions about how to do global health without traveling to another country. We have posted some resources on our webpage, things that you can do, particularly checklists and other things you can do to engage with organizations. I would encourage you to look at that. Here is a question about how do you make sure that organizations comply with community needs, particularly when they may not agree with that because of their own backgrounds and things like that. Judy?
Well, it's tough because there's a power differential that drives so much of this. So who is the you that's going to get people to do it? It's not us. It's going to be those communities. And I remember sharing with you, Shiley, not long ago, remembering when I lived in Boston, and there was a community that was quite poor and mostly people of color. And all the schools in Boston, the students were looking for projects, and they'd go interview and they'd write their thesis. And, and the community finally said, we're not going to be your, avenue to getting your degrees. If you want to do research here, you need to come and clear it with a committee that will say whether it's something that is worthwhile for us. And so it really is the power and empowerment of local communities to be able to say, this is good or this is not good. And I remember very well when I was working with Bruce and we were interviewing people who go with Catholic hospitals on missions. And I was talking with the leader of one of these who said, you know, she works very hard on partnerships and she really appreciates it when a partner says to her, actually, no, we don't want that. Right? Let's talk about something that we might want. So we can be influencers and we can try to educate people. But again, the power differential is great, and the incentives to do things that are not necessarily the most ethical or the most effective are great. So it's got to be about balancing out the power.
Yeah, and just like to add that, you know, the idea is when you have a local community or a local government saying no, then you know you're making progress, you know, because it's easy to say, yes, we'll take that. And when they say, no, this doesn't work, and when they feel empowered and supported, and that's sort of what AGHP wants to do, is get that, you know, empowerment and, you know, the support structure the way it should be.
Yeah, thank you. Here is a very pragmatic question, particularly with COVID-19 right in the midst of us. What impact has COVID-19 had on the development of the declaration? And has it influenced the development of any part of it, any policies there?
Shiley, why don't you answer?
Well, I can talk about the process part has changed significantly. Like I mentioned, we were supposed to be unveiling the declaration at the Brochure conference. We were not able to do that. So we've had to do a series of, and we were all involved in multiple such series, conversations of webinars with different entities from around the world to disseminate the information. And I think COVID-19 was almost like a reset, because if you think about it, there is not any short-term medical mission happening at this time because of travel restrictions. So in many ways, it was an opportune moment for us to stop and ask the question, this is a time for us to reflect on it. So those are the things I think helped. Our process of developing the declaration started before COVID-19 and it continued through now. So so here is a question. Has there been discussion about expanding this work beyond health missions to other areas? Do you think that this groundwork could be effectively used to change the paternalistic nature of volunteer organizations that build houses, clean communities, etc.? Bruce, I'm going to start with you there.
Yeah, I think that while we have focused very much on health, I think there's a similar need for this kind of declaration, this kind of thinking about all of those things. And I think sometimes even on those health missions, people go and build houses and paint and do other things because they haven't done their homework and don't know what to do. And you hear of stories where people go paint the same wall over and over or build houses. But there are also examples where the communities are deciding. And I talked a little negatively about the organization that I worked for before. They did have an amazing system of health agents, and they use those health agents to identify those health agents lived in the communities. They use those health agents that worked in those communities to identify what families really needed a house. And it became a real opportunity then for the fundraising that would happen for some of that, from some of those groups that came in, to actually support the poorest of the poor in those communities as identified by the members of the community themselves. So that's one example.
Just like to add, you know, the painting reminded me of where a group went down to paint this, you know, particular, you know, building. And someone said, you mean that there's no one in that community that would know how to paint that building? We had to come down and paint it for them. You know, it's like, this is ridiculous. You know, if we're not bringing value added, we're not doing something. What are we doing here other than, you know, entertaining ourselves?
Yeah, and I think we were talking about an example of I forget the term, ethical cruise, where they would take folks to the Dominican Republic and give you a day to go and paint a school. Unfortunately, it was the same school, so it got multiple coats of paint to decrease your guilt about going on a cruise. And my point is, go on a cruise, spend money, help the local economy that way. That's probably more effective than painting the school multiple times.
Yeah.
Here's a question. Are there any insight into the involvement of medical schools in helping to produce more globally minded and culturally humble physicians for those who are interested in this work? Judy, you want to get us started on some of the conversations happening in the schools level?
I think that medical schools, in some cases, are at the forefront of this, and UMN being one, but there are others. A number of the questions have to do with how do you establish good partnerships. And I think there are some medical schools that have excellent partnerships with specific medical schools in other countries where they have exchanges and where they do training and so forth. Medical schools are also somewhat at the root of this problem from my perspective, having taught mostly undergraduates, because the competition for getting into medical school has been so great that some of them ask applicants to have meaningful clinical experience, which is not possible in the United States, given HIPAA rules and so forth. So it almost puts applicants in the position of feeling like they have to go to another country to do stuff to get that experience, even if it's bad experience. And in the past, medical schools would see that as a plus. Increasingly, the medical schools, I think, are catching on to that's really not a good example. It shows that you can afford to go, but it doesn't really say anything about what you've learned or what you know. So I think the medical schools have both been leaders and also somewhat culprits. And I think that increasingly they have seen the problems and they are producing some of the research and some of the writing about how it can be done better. Thanks, Shiley.
That's, I think, absolutely appropriate. I think the selection process itself is a huge concern. And until and unless that is fixed, I think there's a problem. Fortunately, I feel that the conversation is moving along better in the medical schools compared to even 10 years ago.
Oh,
We
yeah.
still have some way to go. And you're right, Judy, there are more examples still coming from medical schools, but every year it seems like it's getting a little better on that.
Shiley, I'm sorry to interrupt you again, but I had a conversation last week with one of our healthcare systems that was looking for a clinical interaction. And I spoke to one of the universities and they said if they just want to go on short-term interactions episodically, we're not interested. So it does seem that there's movement in the right direction.
Yeah, that's really good to know. We're almost at the end of the time, and I'm going to ask this of all our panelists because I think this is the ideal question to end it. Is there an ideal short mission trip? And what does this look like to each of you? Myron, I'm going to start with you here.
I think an idea, short-term trip would be something where the local community and the local government would say, here's a need, and then go out and find people that would have that need that they can come in there. And it's got to again be mutually beneficial, but something that this is what we're looking for, and this is going to be short term, but it's got to lead towards something long term. So if it comes from that perspective, I can definitely see some advantages to this. But it's got to be, again, strengthening the local healthcare system to help the people long term. And this is sort of a way to get there. But that is not, short-term missions are not the way to help people long-term.
Judy?
So I think the first thing is that it should be part of a longer-term relationship, right? So you can go for a couple of weeks and do some specialized work or training or so forth. if it contributes to that overall long-term partnership. Interestingly, people always said to me, anytime I talk about this work, they say, oh, you mean Doctors Without Borders? And I see somebody in the questions asked about Partners in Health. Partners in Health and Doctors Without Borders are very well-known, highly respected organizations who do not do short-term mission trips. They hire people locally and they hire people from outside, and it's only for a much longer commitment. So I think we need to understand that the short-term trip has other places that it takes place. So ideally, the people who go are well prepared before they go. They are debriefed afterwards. There is an evaluation of what they accomplished, and not just asking the volunteers what they thought they accomplished, but actually evaluating on the ground. Now, that's a lot. And I want to say that I think there may be a place for a trip where you're not going to actually do anything useful, but you're going to learn. And I think for students, especially for medical students, for other people, going on a short-term trip, which is designed as a learning experience, it's like tourism, but with an educational component. And then you compensate the people who are educating you. You treat them as teachers, not as beneficiaries. And the people who travel are guests, and they have to act like guests. They have to be polite and respectful, the way we expect guests to be. And so, you know, I love to travel, and I love visiting new places and learning about it and talking to local people and learning about what they're doing and so forth. But if we think of it more as a learning experience for when we're not able to offer something, if you don't have skills to offer, right, that are serious skills where you can work with people. And mostly when we ask people, what do you want? We want people with skills, right? The people without much skills, but who are interested in learning, let it be a learning. Let it be clear that they are, that the hosts are their teachers and need to be respected and compensated accordingly. So different models.
Bruce, how about you?
I agree with everything that's been said. I think that the ideal trip would absolutely follow the principles and standards that we've outlined in the AGHP. And I think beyond that, really ensuring that we understand our own motivations and the motivations that those that we're working with to ensure that they're all properly matched.
Thank you, Bruce. I think that's the message I would have to asking, what is the agenda? Whose agenda is it, right? You folks know this. I've mentioned it before that ideally there will be no short-term medical missions, short-term trips. But I've come to recognize the value in well-designed, well-done ones. And also the question, should you really need to travel? You know, we got into a brief partnership with MSSI, the organization that Myron talked about, and we contributed a small part of pivoting their training platforms to online platforms. And we learned a lot from our Ghanaian colleagues in that interchange too. So I think engagement is the way we are emphasizing. We are in a global world. We need to engage. It's not absolutely necessary maybe to travel, and maybe COVID will make us rethink travel even after the next year, the year after. So thank you, folks. I really appreciate you folks coming to this. It's been a pleasure as always. I learn so much from you every time I interact with you.